Hi there, my name is Lee Bowman, and I work with Island Health, Mental Health and Substance Use Intake. I'm also liaison for Aboriginal clients. So I'm here to tell you about some of the services available within Island Health related to substance use treatment. So the first thing I should say is that had this day been delayed another 2 months, I would have had different information to present to you today, because there's a new development happening that's going to really shift the way things work, and that's called the CARE Clinic. So CARE stands for Central Access and Rapid Engagement Service, and it's not ready yet, it's in development. So the idea is 2 or 3 months down the road, it should be available for walk-in assessment and intakes, and also a walk-in crisis clinic. So that means that clients can just present and get referrals on the spot. But right now, what we have is, I want to tell you about mental health intake, substance use intake. So right now, until the CARES Clinic gets up and running, the good news is that referral to any addiction services, substance use services rather, within Island Health is really easy. Clients can self-refer. So they can do that by, for the next couple of months anyway, presenting to 1125 Pembroke Street, which is the site of the Sobering and Assessment Center. They'll be asked to fill out some paperwork. They can get help with that if they want to. And then they'll leave that day with an appointment for an intake interview. Of course, physician referrals are always welcome. I note that in your information packages that you're going to leave with today, there's a referral form. It's just the standard referral form that you should all be familiar with. And then referrals can be sent to the mental health and substance use intake fax line, which is all one. It's going to be one fax number for both addiction and mental health services. So I brought a bunch of handouts that tell you about every single one of the addiction services that are available right now, but I'm just going to focus on a couple today, and then you can read the handouts at your leisure about the other services if you want. If you have any questions about any of them, of course, you can give me a call or another intake clinician a call, and we're happy to answer questions. So probably the most useful resource for most clients who are engaging in opiate agonist therapy would be the Addiction Outpatient Treatment Clinic, otherwise known as AOT, and that's at 1250 Quadra Street on the 2nd floor. Again, clients can refer themselves to that by either calling the substance use intake line or by just presenting to the 1125 Pembroke Street. The AOT clinic has a lot of really great services. They offer individual counseling, but on kind of a limited basis. The counselors there are really, their primary job is case management, in that they make referrals to residential treatment programs outside of Victoria, for example, and also they can refer to mental health services. They can also refer to the addictions medicine physician that works at the AOT clinic, and that can be helpful for clients that are interested in finding out about how substances affect their bodies and brains and behavior, and also for information about possible medication help. And a lot of people have questions about whether they can take antidepressant and anti-anxiety medications along with other kinds of services. So I'll move on. So the AOT clinic also offers drop-in groups for that, gender-specific drop-in groups. There's a drop-in group for people that have concurrent disorders, and there's also a drop-in group for LGBTQ clients, and they also offer intensive day treatment programs for both men and women, and those are programs that are designed to deliver the intensity of a residential treatment program, but in an outpatient setting. So that's that. I guess I won't say very much about the Rapid Access Addictions Clinic because there's an expert in the room right now, but I can't remember whether it was said, but clients can also refer themselves to that program as well. The clinics have a drop-in time from 9 o'clock to 11:30 on the days that it's open, which I understand the days have extended. It used to be 2 days, Mondays and Fridays, and now it's open a few more days a week. And just for your information, in case you're not aware, there are alcohol and drug counselors that are working at community partners. So your patients can see an alcohol and drug counselor from Pacific Center in both the West Shore and or I think it's Colwood actually, and in Souk. They also have alcohol and drug counselors at the Kool-Aid Clinic and at the Victoria Native Friendship Center, and the Umbrella Society is a service that I think they're going to be talking today, and they'll tell you more about their service, but they're really helpful in getting people engaged to some of these services that have been talked about today. Just because I'm here, and the only reason I'm here today is because I happen to be one of the few people that works on Saturdays. So, but I'm also the liaison for Aboriginal clients, and I've been doing that since 2010. And Bill was mentioning that one of the frustrations for a lot of physicians is that they give their patients information about services and where to go, but the clients don't follow up. So I can be helpful in that regard when working with Indigenous clients. So my role was created in order to reduce barriers to service for a population that hasn't always felt very well cared for and safe in our healthcare system. And so one barrier that's reduced is clients can actually just call me directly on my cell phone. By the way, I did bring a stack of cards, so you can take one of my cards. If you want to refer, you can do so by telephone or by physician referral form. If you are going to send in a referral via fax, it's really helpful if you put attention Lee, L-E-E, on the referral form, and that way it'll come to me. Okay, got it. So I think that's it.
Great.
Yeah, hi, I'm Jenny Dagg, and I'm an outreach worker with Umbrella Society for Addictions and Mental Health. And specifically, I'm the outreach worker for the Physicians Pilot Project, which began in March of 2016, and is a collaboration between the Department of Family Practice and Umbrella. The work I do is based on our very successful peer outreach program that began about 16 years ago. And the peer outreach model is very simple. People with lived experience, helping those who are struggling with substance use issues. So all of our outreach workers have personal experience in addictions. We provide one-on-one support to the clients. And sometimes, as Bill said, we are the first people, we're the first point of reference for people in starting this journey in recovery. And one of the goals is to help relieve some of that guilt and shame they're feeling when they're at that time of their lives when they are ready to talk about it or perhaps make a change. And so I consider part of my job to normalize that for them and to help them realize that there is hope and there's lots of help out there for them. We meet people in the community, out for coffee, go for a walk in the park. Part of what we do is refer them to all of these other community resources that are available and help them kind of find their way, because it is kind of confusing. There's a lot of things out there, and where do you go and how do you get there and what's the wait list like and all that sort of thing. The great news about the the physician's pilot project is there is no wait list. Umbrella does now have a wait list in all of the regular peer outreach, but with this project, there's no wait list. You refer directly to me. My number is in that handout that was given with all the, what's this handout, with all the services in, my direct line. So you're welcome to call me or text me, or also your patients are welcome to do that as well. I do work regular hours, so not at 3 in the morning or anything. We're not crisis management. We are support. So sometimes I have people that call me right from their office with somebody that is looking for some help, and I just take it from there. There's no paperwork for the physician. You guys just give me an idea of who I need, a phone number, obviously, and a name, and whether it's okay to leave a voicemail. And I do the rest, and I will arrange to meet them and see what they would like to do, whether or not they might like to go to a community support meeting, 12-step meeting, or if they just want to talk and have coffee and talk about what's up. So that's basically what I do. And Umbrella has a number of other initiatives. They're involved in the, we have a worker at the RAC Clinic. We have a worker at the Pandora Clinic now. We have a drop-in group also at 1125 Pembroke, Tuesday and Friday afternoon, for people and their families, in fact, who are just waiting for supports, waiting, or in a waiting list somewhere, what's available for treatment and so on. So that's kind of what I do.
Great.
Okay?
Thank you.
All right. I've borrowed a set of slides. I'm Nelson Svorkdahl, Medical Director at the Pain Program at the Jubilee Hospital. And I think that I was originally told that I'd have about 5 to 6 minutes, and then I was told I have about 3 to 4 minutes, and someone then said I have about 2 minutes. So if I start to talk very rapidly and I start to lose my verbs, then raise your hand. So the pain program is a multidisciplinary program that is funded by VHA. We have 3 different sites that was started in 2007. We have sites at the Jubilee Hospital, Nanaimo Regional General Hospital, and a satellite group in Comox as well. And the multidisciplinary nature of our program is such that we recognize that pain is a disease. It is not just a symptom. And that there's an element of autonomy that occurs with pain, as we all know from neuroplasticity. And so our approach is in some ways similar to treatment of ischemic heart disease, is that we make a diagnosis, we try and be as targeted as we can, we try and treat the underlying process in order to help function, enhance compliance, so that there's a rehab component, a pharmacological component, an interventional component, and of course the patient has to buy into it as well. And so I think that when we are working with our occupational therapist, our physiotherapist, our social worker, our nursing staff, our psychiatrist, our psychologist. We have a neurologist on staff as well. We have an ENT surgeon that helps with head and neck pain. We have 3 interventional anesthesiologists as well, Doctors Davis, Kahn, and myself at the Jubilee Hospital. And we have a clinical pharmacologist as well. We try and address multiple aspects of the patient, from the diagnosis, rehab, intervention if necessary, and management, in order to help the referring physicians get the optimal benefit we can for those patients. We try to, so that's our whole group. We try to keep things relatively efficient. And one thing that helps our efficiency is in the referrals that come in. A referral that isn't so efficient is, my patient has back pain. Please see and assess and treat. That would not be an ideal referral. Something that is specific with appropriate imaging, trial pharmacotherapy, initiated rehab therapy, comes in with imaging demonstrating patient has facet arthropathy at L4, L5, and peridiscal inflammation at L5S1. What recommendations do you have for managing, intervening on this patient in order to help with their management? Would be a succinct type of referral coming in. So I think our ability to be efficient helps with the quality of the referrals that comes in as well. There's a multitude of, now this is a busy slide, and our referral form is in a constant state of reassessment and renewal as it is now, but essentially we want to make sure that the physician and the patients are agreeable to the recommendations coming back, so that the buy-in, the compliance aspect, can help them progress. Our waiting time. As I said, we try to do things in order to be efficient. And it was interesting that you mentioned that in St. Paul's Hospital in Vancouver, the waiting list is anywhere from 18 months to up to 2 years to get into the pain program at St. Paul's Hospital. Ours, depending on the underlying pathology, may be somewhere around, on average, 2 to 3 months. If it's a malignancy or an ischemic condition, we'll see them much more rapidly than that. If it's complex regional pain syndrome, we'll try to see them much more rapidly than that. But on average, we're trying to see patients as quickly and efficiently as we can so that patients don't suffer from the deconditioning of being left without management for sustained periods of time. And I think that hopefully if we can try and achieve that, it may prevent some of the dysfunction that comes from the deconditioning. Part of that is our approach as we talked about today, is opioid reduction. And through some of the combination therapy, hopefully opioid reduction can be something we can help to achieve as well, because we've heard about the downsides of excessive doses of opiates as well. And so that is sometimes one of the goals that are set out by our patients when they come, and certainly by the clinicians. But another referral that we haven't appreciated recently is, my patient is on opiates, please wean them off. That isn't so helpful either, because I think that it's the opiates that they're on isn't the problem. The underlying issue is, what's their diagnosis? What's the best management strategy for this patient? It isn't simply take them off so I don't have to prescribe anymore. So I think that in a nutshell is who we are at the pain program. I think some of our colleagues are at the back. If our pain group wants to stand up at the back, we have several people back there as well from the pain program, and feel free to approach them. Doctors Bosley, Davis, Kahn, Linda McCune, and Caddy, our occupational therapist, have come along today and may be able to answer some of your questions later. Thank you.
The Pandora Clinic is one of the 2 opioid agonist treatment clinics in town. I work there. Joyce Koost works there. I don't know if anyone else here is from I don't think any of the other docs, but there's about 8 or 9 docs who work at Pandora, and it's a long-term opioid agonist treatment clinic. And it's located on Pandora, and we only manage opioid use disorder there. And that's where patients go from the rack if they don't have a primary care provider to be able to continue prescribing long term. It's a walk-in. People can walk in and get started there. Often there's a wait of a few weeks to get in to get started there. And that's the reason that the Rapid Access Clinic has tried to increase access. But I don't think there's too much else to say about the Pandora Clinic. Anything else?
Umbrella worker.
Recently we've expanded personnel, so we have an umbrella worker working there now 4 days a week, and we have a counselor working there 4 days a week as well too. The one other opioid agonist treatment clinic in town is the Outreach Services Clinic, which is another clinic. I don't think we have on our list to talk about that, but it's another clinic. That one has a fee to go, whereas Pandora does not.
And just to clarify, this is for not for pure pain patients. This is for people with opioid use disorder.
Only opioid use
Yeah.
disorder.
Okay.
Not
Important
pain at all.
important
And the Rapid
distinction.
Access Clinic is also only for people who have opioid use disorder, not for people who are on opioids for pain. If they have both, then for sure the RAC is appropriate for them, but not if they just have pain and they're on opioids.
Okay, thank you.
My name's Liz McCarter. I'm part of the UVic, University of Victoria self-management programs. They offer many self-management programs, from healthy living with chronic conditions to diabetes self-management to an online self-management program. And I'm here today to talk about the chronic pain self-management program. It is self-referral, and it also can include, can you hear me all right? Anyway, I'm the youngest, so I'm in my family, so I thought I have a pretty good loud voice. It's self-referral. Family, friends, and caregivers are welcome to participate. It's an evidence-based program. The courses are designed through Stanford University, but University of Victoria, the Institute on Aging and Lifelong Health, the old Center on Aging, runs the programs here in BC through Dr. Patrick McGowan. The material has been Canadianized, so it meets the needs here. I've photocopied a pink sheet that's on the tables out there. It covers all the topics covered in the 6-week program. It is free. It is lay-led, so all the leaders go through a 4-day training. I'm a master trainer, so I train facilitators. They also get this great resource book. It's called Living a Healthy Life with Chronic Pain, and inside it is a CD, and it's called the Moving Easy program, and it gets people started with a physical activity program, and we do that through the 6-week program. What else do you need to know? I've told I was going from 10 to 5 to 2 minutes, so let's see, how am I doing? The best tool that they learn is action planning, and I think many of you use brief action planning in your practice, so it's a great way to coincide and work with your client who've been doing any self-management program, is to use the action planning and the problem-solving tool. In the 6 weeks, they get a toolbox that they can reach into and use throughout their life, and it's really to help them, support them in their pain journey. And I have to say, when I facilitate the 6-week courses, you see the transition of people going from very upset and angry and negative to now practicing and gaining some control back in their lives by using the action planning and having some success. So you can see the transition happen in the 6 weeks, and many of the people who are in the group for 6 weeks gel, and they continue to meet each other and support each other long after the course is over. So that's all I have to say.